I'm glad that we are with you. We are here to present the Multimorbidity Task Force, which is an IPCRG initiative about the multimorbidity management in COPD. And Boehringer Ingelheim provided an unrestricted educational grant to support this activity. So we will present together with Claudia Vicente, a family doctor that is interested in respiratory diseases, and she's in Grespo from Portugal. We will present a complex case in a woman with COPD, and I am Ioanna Tsiligianni. I'm also a family doctor with a special interest in respiratory diseases and the past president of the International Primary Care Respiratory Group. So please feel free to use, update, and share some of these slides in your non-commercial presentations to colleagues or patients. And here you will find a general introduction to multimorbidity management in COPD, and we hope you will find them useful. What you will learn from this presentation is why, as GPs, we have to focus on multimorbidity, what multimorbidity means in people with chronic respiratory diseases, how can we improve the management of the patient with chronic respiratory disease and multiple comorbid conditions, and how you can really be part of that change. So patients with COPD typically also present with multiple comorbid conditions, which may require long-term management alongside their COPD, while an additional challenge is that concomitant conditions can be overlooked because signs and symptoms overlap with those associated with COPD. And surprisingly, up to 80% of patients with COPD will have at least one comorbid condition of clinical relevance, while half of them will have 3 or more. Comorbid conditions are more frequent in women than men and increase in prevalence with worsening COPD severity. Comorbidities often appear in clusters, which suggests common risk factors like smoking and inactivity. They share underlying pathobiological mechanisms, such as accelerated aging and side effects of COPD treatment, while the most common comorbidities in patients with COPD include all these that you see here: cardiovascular diseases, metabolic syndrome, diabetes, osteoporosis, mental disorders, lung cancer, bronchiectasis, muscle weakness, and obstructive sleep apnea. The management of individual patients with COPD and multimorbidities is often very complex because it requires the simultaneous application of several disease-specific treatment guidelines. These guidelines are not always well aligned with regard to treatment recommendations in the face of multimorbidity. Therefore, an holistic approach is of particular importance for patients with COPD. Primary care physicians should seek to undertake at least annual reassessment and treatment adjustment for patients with COPD. Emergence of multimorbidity should be regarded as a signal and call to action to undertake a review of the COPD treatment, because this is really important. And in this set of slides, we will focus on COPD and the whole patient context in order to be able to show you how to deal with them and how to prioritize in line with the patient. For patients with COPD, multimorbidity is associated with a high level of polypharmacy and an increased risk for adverse drug reactions and interactions, an increased risk of hospitalization, and an increased risk of premature death. Polypharmacy is of particular concern when drugs with potential for similar adverse reactions are combined and when comorbid conditions and adverse reactions to treatment look alike. According to Goal 2020, multimorbidity should not delay the treatment of COPD, and comorbidities should be managed according to usual standards. Unfortunately, the case is not that, because this is not so simple, and we have to see the patient in an holistic way and take in consideration all comorbidities and different guidelines. So attention should be directed to ensure treatment simplicity and to minimize polypharmacy. So what shall we do? We have to optimize the treatment regimen according to GOLD classification and assess and treat comorbidities. But for patients with multimorbidities, we have to undertake a review of COPD treatment with a focus on the interface between symptoms of comorbid disease and side effects of medications. In addition, we have to think carefully about the indications for inhaled corticosteroids used before prescribing, and use in line with guidelines recommendation, and note the latest IPCRG advice on appropriate use of inhaled corticosteroids and guidance on inhaled corticosteroids withdrawal. You can see in the footnote where to find these details. Here are some additional essential action points. So we have to increase awareness of COPD multimorbidity and screen and monitor patients for the most common comorbidities, ensure at least yearly patient reassessment and treatment adjustments, review inhalation technique and adherence to medication, empower multimorbid patients with COPD and caregivers to help them cope with potentially overwhelming amounts of information and, of course, associated with mental disorders, evaluate the indication before initiating inhaled corticosteroids, closely monitor for cardiac rhythm disorders, including atrial fibrillation when initiating patients on LABA. And also we have to monitor for emergent urinary symptoms when initiating patients with chronic kidney or prostate disease on LAMA. With regard to ongoing inhaled corticosteroids, we have to consider, in case of an asthma, that inhaled corticosteroids should be continued. In case of diabetes, to reconsider if inhaled corticosteroids treatment is needed, because if inhaled corticosteroid is continuous, a close follow-up glucose monitoring and titration of anti-diabetic treatment is required. And also about osteoporosis, we have to reconsider if inhaled corticosteroids treatment is needed, because if inhaled corticosteroids is continued, a close follow-up for loss of bone mineral density to risk of fractures is required. Let's don't forget the infections, pneumonia or tuberculosis, where we should consider withdrawal of inhaled corticosteroids and maximization of bronchodilation. So our aim today is to use a case study to teach how to identify and manage the multimorbidity of people with COPD. And here I welcome Claudia to continue this case.
So now I will present a complex case with multimorbidity that talks about Mrs. Vitalina. Mrs. Vitalina is a patient that is 70 years old. She's Caucasian. She was born in Mozambique, but now she lives in Milhada, that is a small town in the center of Portugal. She's married and she went until middle school, and she's the owner of a small car company. She doesn't have any alcohol consumption and she doesn't smoke, but she has a passive exposure because her husband smokes a lot, about 80 pack a year. And at home, she has an unprotected wood burning fire. That's how we know it's a risk factor for COPD. And he has a limited exercise. She has lost about 5 kilos in the last year, and she feels very often very tired. She doesn't have any allergies, and she's updated to her vaccinations with influenza and anti-pneumococcal vaccinations. About her medical history, she has a lot of diseases. She has to deal with hypertension, atrial fibrillation, mitral valve prosthesis, dyslipidemia, depression, osteoporosis, diabetes, and COPD. And we'll have to look a little bit about frailty that is connected to all these diseases all together in the same patient. She's doing a lot of medication, a polypharmacy, that is a consequence of all these diseases. She's taking perinappril 5 milligrams plus amlodipine 5 milligrams 1 time a day. She's doing atorvastatin 10 milligrams, warfarin, escitalopram 10 milligrams, alendronic acid, metformin, and for her COPD, she's doing salmeterol with fluticasone twice daily in discos. And when she has some issues, she does salbutamol as needed. So Mrs. Vitalina came to a hypertension consultation, and the family doctor looked at her, and he knows that she has serious family problems, but she never complains about anything. Sometimes she asks for assistance from social workers for her husband, who has had a stroke and he's bedbound. When consulting the records, the family doctor finds 2 moderate exacerbations of COPD in the past 12 months. So in Portugal, we have an electronic national health register, and this was pointed to time for uncontrolled COPD, which were treated with oral corticosteroids. When the family doctor asked her about the cough and the shortness of breath, she said, "I'm always a bit tired. I still have cough in the morning, and I take my respiratory medication every day." So Mrs. Vitalina is that kind of patient that doesn't complain. The doctor has to ask her about her respiratory symptoms. So the doctor, after the medical history, does the physical examination. She doesn't present at that time no signs of respiratory distress. She has a blood pressure of 138/94 and 80 beats per minute. Her cardiac and pulmonary auscultation are normal, but on the pulmonary auscultation, we can find a little bit the murmur diminished, and we don't have any extra sound. She doesn't have edema of lower limbs, and she has a normal body mass index about 23.4 kilograms per meter. So we know that clinical COPD is different in men and women. In IPCRG, there was an initiative for doing this desktop helper where Ioanna, that is present here, was involved in all this, in this initiative. So we know that women has to be looked at different as men because they are often underdiagnosed and they have suboptimal treatment. They have a different COPD presentation, and they have also a different socioeconomic status. And also in the burden on comorbidities, they are also different. On this desktop helper that you can download online on IPCRG website, you also can find some questionnaires used to assess health status and mental health care depicted here. So this can help us on Mrs. Vitalina, because she's an example of women with COPD. She had 2 exacerbations in the past 12 months. She has a lot of women comorbidities that are associated to women like osteoporosis and depression, and she has a passive exposure to tobacco, and she has at home unprotected wood burning fire. So getting all the information, what should we do with such a complex patient with COPD like Mrs. Vitalina? We have to assess the adherence to therapy, and Mrs. Vitalina do it everything okay. We have also to access inhaler technique every consultation, and the doctor did that too, and he saw that Mrs. Vitalina could do her inhaler. And we have to look for other exams and to see how we can reassess all the COPD condition and all the comorbidities. So we ask for a spirometry. So we have here Mrs. Vitalina spirometry. We can look at the curve, and the curve reflects an obstructive disease. Now let's look at the data. We have a relation FEV1, FPC of 61.37 post-bronchodilation, and she has a non-reversible obstruction. So we can see by this data that she has COPD, and the FEV1 is 68.1, which help us to classify Mrs. Vitalina as a gold 2 patient. Getting more information, besides the spirometry, we have a chest X-ray that is normal, and also blood tests to see the eosinophils. And we can see that Mrs. Vitalina has no eosinophils. And about the cholesterol, she has 212, and what we can see here that make us be more alert, it's about the LDL level that is very high. Our goal for Mrs. Vitalina should be under 40 milligrams per deciliter, and she has almost 3 times more, 118.5. Thinking about Mrs. Vitalina clinical picture, what we have here, we have a COPD that is not well controlled with her current medication, that she's doing well and with a good inhaler technique. And she has a very high number of comorbid conditions. Diabetes is not optimally controlled, and the same happens with depression that comes from her problems, and hypertension, and also dyslipidemia. Besides that, the medication, she has diabetes and osteoporosis, and she's taking inhaler corticosteroids. And maybe for this patient, this is not the best option for treating her COPD. So we have some challenge associated to Mrs. Vitalina. She has 7 comorbid conditions. That is a lot. She has to deal with a lot. And besides, she takes 10 medication every day, plus her reliever that she's taking a lot, because as we saw, she had 2 exacerbations in the past year. Her COPD, so it's not well controlled, and it's not optimally treated. But we have some positive points with this patient. She's a good patient. She's up to date with her vaccinations. She's a non-smoker patient, and she adheres well to her medication. And besides that, she has a good relation with her doctor, that we know that is a very important thing to control all the diseases. Besides that, she has done all the cancer screens, and they have all been negative. So we applied CAT tests to measure symptoms controlling Mrs. Vitalina in order to choose later, using GOLD guidelines, the best treatment. She scored 28 points, which means that COPD are not well controlled, which means this is a symptomatic patient with a very high impact in her life quality. So let's reevaluating Mrs. Vitalina COPD. She has a CAT score of 28. She has 2 moderate exacerbations in the past 12 months. She has a FEV1 68.1% pre-bronchodilator and 73.47 post-bronchodilator. She has no eosinophils, and she's a non-smoker. With the exacerbations that she has had, and with the CAT score, we can see that Mrs. Vitalina is a group D with GOLD evaluation. And this helps us to choose which is the best medication for her. And as we can see, she's not well controlled with ICS/LABA. And besides that, she has other comorbid conditions that will take us to withdraw ICS, like diabetes and osteoporosis. So we can see that she has a profile of an exacerbation patient. And when we have an exacerbation patient with no eosinophils and non-smoker, we have 2 options when we are under a therapy with LABA ICS. We can go under triple therapy, or we can try double therapy, that we think it's the most wise and choose choice at this point. We can change Mrs. Vitalina from LABA ICS to LABA-LAMA. And why? because we want to manage exacerbation. We want to withdraw the ICS because of the comorbidities that are very important. And we have to choose wisely because she has a lot of diseases, and we have to choose the best medications under this polypharmacy. So she must initiate LABA/LAMA, and it's highly recommended to refer this patient to pulmonary rehabilitation. So what else can we do? Besides the medication, we have to do a self-management education, maybe a written action plan that is personalized in respect to avoidance of aggravating factors. The most important here is avoid the unprotected fireplace, and how to monitor and manage the worsening of symptoms, because in the beginning of the clinical case, we have seen that Mrs. Vitalina doesn't value her shortness of breath, her tiredness. And besides that, with the contact information in the event of an exacerbation once ICS has been withdrawn. So which are the next steps for Mrs. Vitalina? We've been talking about it in the past few minutes. ICS should be withdrawn for this patient because there is no indication of clinical benefits for her, and because they are contraindicated given her current comorbidities like diabetes and osteoporosis, because we know ICS can worsen these diseases. She should be initiated on dual bronchodilation with LABA/LAMA, and she should be trained or accessed for her inhaler technique, and ideally maintain the same inhaler when possible. This training should be done every single appointment and start the faster that she can with pulmonary rehabilitation. We have to think, besides COPD, we have to optimize the treatment of the other medical conditions. What else her doctor can do? On diabetes, he can assess therapy and adjust dose or add a new class of anti-diabetic therapy. On depression, we can increase the doses of escitalopram from 10 to 12, or offer other psychological support that I think maybe it will be needed, because it's chronic depression with along with personal problems. And it's also very important to adjust hypertension and dyslipidemia treatment. Like we can increase perindopril from 5 to 10 milligrams, and then make a new evaluation. And besides that, rise the torvastatin from 10 to 20 milligrams. For the atrial fibrillation, she can maintain the warfarin, and she has to do the control. And for osteoporosis, we can maintain the therapy, but for how long? We need to know for how many years she's doing this, and if it's still needed. So this it's important to balance the treatment and do a new pharmacological plan. It's very important to balance the withdrawal of ICS and starting the dual bronchodilation at the same time that she starts the pulmonary rehabilitation. It's important to assess the inhaler technique and the diabetes therapy with all the doses that I've been referred. And one thing at this point that is crucial is check for the next appointment to reevaluate all the adaptation that the patient does to this new pharmacological plan and to her new inhaler bomb. So now we'll continue with Dr. Ioanna, and she will talk a little bit more about this pharmacological plan and how to reassess the other medical conditions.
Okay, so when managing this patient and the comorbid conditions, we should remember to reaffirm the diagnosis, make an initial assessment, reevaluate the management, and always adjust and review. The review should include the symptoms, the exacerbation, the smoking status, the exposure to other risk factors. We shouldn't forget inhalation, physical activity, the self-management, and if possible, the pulmonary rehabilitation. But we shouldn't forget also the management of comorbidities as we did in this case. And we shouldn't forget the frailty. Frailty is very important, and it is rarely mentioned in the guidelines for the COPD. So frailty is considered highly prevalent in old age and confers high risk for falls, disability, hospitalization, and mortality. It has been considered synonymous with disability, comorbidity, and other characteristics, but it is recognized that it may have a biologic basis and be a distinct clinical syndrome. The important thing that it is an independent risk factor for the development and progression of COPD, and COPD can lead to frailty. Therefore, frailty and COPD affect each other. Both frailty and respiratory impairment can be modulated and treated. When one is treated and or prevented, the other may be improved. This, I think, it's very important and a very important slide, because as clinicians, we often forget how frail are these patients, and we should always assess. There are many screening tools. We decided to present some of them because maybe you, as we are, not familiar with many of them. So most of the tools that are for screening of frailty in clinical settings are not designed to be self-administered. There is the frail scale, which counts the fatigue, the resistance, the ambulation, the illnesses, and the loss of weight, and it is a rapid screen for frailty. The fried failed phenotype is the most frequent cited frailty tool and has been used to predict mortality and adverse clinical outcomes in large cohorts. And the frail non-disabled questionnaire is constructed based on the widely used frailty phenotype, including 5 main criteria: unintentional weight loss, self-reported exhaustion, weakness, slow walking speed, and low physical activity. But it also includes a specific section for exploring the presence of mobility disability. So we want you to consider using one of these questionnaires if possible to assess frailty. Our patient indeed was frail, and in the footnote, we give you some examples on where to find the screen tools. And with this, we want to thank you for being with us. I want to thank Claudia as well. We hope you will find it useful. All this material will be in the IPCRG website, as well as our emails in case you want to contact with us. Thank you, Claudia, and thank you, everybody.